Manoj forgot to say that I'm his friend, so I'll add that as one of my qualifications. Thank you. This is my conflict of interest. I serve many masters, and each of them have a say in what I do. But thankfully, I'm talking of something that affects all of us. The first question is, and this is a question that's bothered us. Can I ask for a small favor? Can I not have that light blinding me? I don't want to look pretty on the TV. Okay. The first question that we need to ask is, after 25, 30 years of fancy medications, tremendous number of five-star dinners and lunches and conferences, workshops and books and all of that, are we better now? Are our patients living longer? Are they living healthier? Are they living smarter? Are they spending less out of their pocket? And are they happier because of their therapy? And how many of you think the answer to this question is yes? Not one hand. How many of you think the answer is still no? A few hands, and rest are asleep. Okay. This is the hard truth that many of us have to face when dealing with diabetes. We are basically a group of people who are pushing and nudging drugs, not knowing where our patients are going. The problem also is that our goalposts are being moved so frequently by all the associations, all the guidelines, and all the talks, that there is a trust deficit between us and guidelines, and I'll come to that in a moment. But if you look at the data, and this is looking at between 1988 to 94 and 99 to 2002, right up to 2010, you will notice that these giant structures that are on these have very little in terms of statistical significance. That the number of our patients who are reaching A1Cs less than 7 is still not tremendously improved. The number of patients who have blood pressures under control is not still improved. The number of people who have target LDLs, now there's no target LDL either, has not changed much. Now you can call this, and this is despite the fact that every drug that comes into the market claims that it's God's gift to mankind, isn't it? So where have we gone wrong? This is where we have been in the past, the old paradigm of diabetes. Lifestyle is started, patient comes to us, you put him on diet and exercise, and 3 months later he comes and he says, can I start you on metformin? And then he says, no, doctor, there were 2 marriages in my family last week, I had 1 kadukuttal last week, can I please, give me 2 more months? 2 more months take place, then he comes back and you start him on a small dose of metformin. Another 3 or 6 months later, you talk about another drug. That doesn't materialize of some other reason. And ultimately, by the time he gets on insulin, it's almost 9 to 10 years. This is despite the fact that we know, and I don't want to go through this because in this conference, probably this slide has come out about 20 times, that if you wait for too long, it's like closing the barn door after the horse has bolted. That the longer you wait, diabetes becomes, even if you treat, there are no differences in outcomes. That includes both macrovascular and microvascular complications. And therefore, you really need to be doing more early. This, every one of us has heard 120,000 times. But despite that, what has been happening? We have no results. Nobody is ever told, our patients are not doing any better. Let's look at this a little more carefully. This is I'm sorry about the lack of the reference here, it's blocked out, but this is a large study that looks at about, 451 patients. Look at the number of people who've been in an A1C of 7, and this is fairly a good number, this is 50%. And about 30% are over 8. Now, it's important to remember, and I'll show you some follow-up data, it doesn't mean that these patients are forever in 7. They have reached 7 once. Look at the LDL levels. If you're looking at less than 100, and you're seeing that roughly 1/3 of patients have reached this. Blood pressure, 1/4. This is despite the amount of work that we claim we are doing with our patients. So either the drugs that we prescribe are completely bogus, or there is something completely going wrong in the way we deal with our patients. So some fancy epidemiologist in the early 2000s coined this term clinical inertia to put the blame on the system. And he said, the clinical inertia is a failure to initiate or intensify treatment in a timely manner in people with diabetes whose health is likely to improve with intensification. Remember all the adjectives here. Then maybe there's another way to look at it, and he said failure to intensify treatment of a patient who's not at their evidence-based goal. And of course, Dr. Phillips said that this is a recognition of the problem but failure to act. So this is the term that has been used, this has been questioned, and what we will do is, irrespective of it, is we all know where we want to go. The problem is we are unable to reach that position. And as I will point out to you in the next few minutes of whatever is left of my talk, is that this is not just doctors alone, it is the entire system. And knowledge of how this is happening is probably the first and the best way to be able to combat it. Whether if we will be able to combat it at all. Oh, I can't. Wait. There's supposed to be a table here that is not shown up, but this just shows that irrespective of what you have, and this is an 80,000 patient cohort that was published in Diabetes Care 2013, and the table found itself nice to disappear in this particular moment. It showed that very few patients will spend less than 10% of their time in an A1C of 7 during a follow-up. So which means all this meeting targets is completely baloney. As I was talking in another meeting yesterday, that if you look at the entire history of insulin, there is till 2007, there is not a single study that shows anything more than 45% of patients will reach an A1C of less than 7. And this is all published studies. Now, immediately all the diabetologists and the endocrinologists in the audience will say, you know what, that's with primary care. And I can tell you, Manoj, myself, Prasanna, maybe Dr. Bolton, we are no different from anybody else. We may be a little better at starting insulin a little early, but pretty much the way we keep our patients in target and keeping them there is tremendously dismal. And I think the sooner we understand that, the better. Now let's look at it. Is this inertia hurting us? I've sort of adapted this data. It is not, I had to pick it up from different places. For every 1 in 20 patients who we don't meet inertia, for 1% of patients with A1C greater than 7, they will have a microvascular event in 5 years. So this is not insignificant. This is a good number. For any LDL above goal, remember there are no goals now, 1 in 20 patients in 5 years will have an MI or a stroke. For a BP 10 millimeters of mercury above target, will have MI or a stroke and progressive microvascular disease. So this inertia is hurting us. But is there something that we can do about it? And to know about it is to start doing something about it. This is the glycemic burden of clinical inertia. Look at this. This is sulfonylurea plus metformin. Remember that this could be anything else. Mean HbA1c during sulfonylurea metformin among the people who maintained 8% goal was around 7.2. Attained but did not maintain 8% goal, 8.1. Never attained 8 this thing was about 10%. The mean months until goal was attained was about 10.3 months. The number of time it was below goal once it was attained was about 44 months. And if you look at this, the mean glycemic burden was around 11.1 here and 31.8. And in all of this, look at this one, about 63%, for 63 months, these people never attained a goal of 8%. That's humongous numbers. So let's go back. I'm going to redefine what is clinical inertia. It is a failure to intensify therapy despite glucose control, but because of competing demands. It's not because the doctor doesn't want the A1C to come down. He wishes it because that's his success. But there is something else happening. There are other factors that are making sure that this doctor does not meet patient demands. And what are these? One, physician factors. It could be a simple reason, this guy didn't know that he had to increase, didn't know how it was to titrate. What is more likely is to underestimate what the patient needs and not look at other factors. The patient may be depressed, he may be living alone, he may be poor. You would have written the fanciest gliptin with an SGLT2 with metformin, and he would have to sell his Mangal Sutra to buy that. He would have probably underestimated that. But there are three other things. For most of us physicians, it's insufficient time. For many of us, it's insufficient focus. A lot of time in the interview is probably spent on a lot of things except what is important. And it's been shown, it's not just shorter the interval, but sometimes the longer the interview, the longer the time you spend with the patient, you may sometimes lose focus of what needs to be even more important. It may be a small itch the patient has, it may be a lack of sleep the patient has, and any time this interview is lengthened, okay, you take the same medications and come back next time. You've seen this happen. Patient would have come, doctor, I have a headache. Oh, okay. It was lasted for 3 days. Okay. Oh, I couldn't sleep at all, doctor. Okay, shall I order a test for you? No, doctor, it was last month, it is over now. At that moment, your irritation sets in. Then you realize then suddenly your assistant will come and say, sir, 14 patients waiting outside. Then what do? You would have seen the 7.5. What will you say? Continue same medications, we will meet 3 months later. Yes? No? Have you done this? I have. This is lack of focus. Second is not being proactive enough. A lot of times our patients remind us, sir, my sugar is so bad, sir. We don't set these expectations and clear targets to them, that we are not proactive, we are reactive to numbers. This happens, so let's do this. This happens, let's do this. We never discuss plans with them. I don't do it. I try to, but I don't do it. So what predicts these things? As the patient concern increases, as the number of other arbitrary things he talks about, this happens. As the length of the encounter increases, the physician's desperateness to get the patient out of the office increases so much that he loses focus. And remember that the average prescription that you're writing is probably 6 drugs minimum, of which 4 are not required. And as the length of this drug prescription becomes increased, now what happens is, as the collateral number of drugs, complaints keep increasing, 1 vitamin, 1 antioxidant, all placebos, one methcobalamin, every drug that is never useful in patients is added purely because it is used as a substitute for us talking to the patient. So what happens? The main focus on the patient's problem goes away. Great. And of course, last A1C is a good one. Now, on top of this, there are people like me who are bald and grey, or prematurely bald and prematurely grey also, who sit in these guideline committees. And a lot of people think that this is one of the reasons that inertia occurs, because these European guidelines are great because they have to meet, as Dr. Bolton talked about, fiscal issues. So what will happen? They will say, you start lifestyle, give it 3 months. You will start, then give metformin, give it 3 months. Then metformin will fail. You start one more drug, give it 3 months. Then you start insulin, wait for 3 months. This patient had an initial A1C of 14.5 and had symptoms. Is this how? So the time that something reasonable was done is 9 to 9.5 months. So in a way, a lot of people believe that the guidelines are the ones that are killing us. Normally, what would you have said? If a patient had come with 14.5, look, I want to get your sugars down. I want you on 4 or 5 drugs, or I want you on insulin. And this is how you treat. Oh, but last week I attended EASD. They had these guidelines presented. This is exactly what happened. So there is a trust deficit that is going on. For example, you may not know the guidelines, or you may disagree with them. How many of you here follow guidelines? How many of you follow guidelines? Chairman, do you follow guidelines? How many of you don't follow guidelines? See? Second, we may all talk about guidelines in conferences. But when it comes to our patients, we will think that this guideline is not for us. Yes or no? Then, patient's characteristics. What is the single most reason you don't up-titrate a drug or start insulin? Because tomorrow he will run away and go to another doctor. Isn't it? Then, you know your patient. How many of you, I don't know how many of you are patients here or as well, but how many of you take your medications every day? But how do we expect our patients to also take it? So let's talk about it a little bit. Then on top of it, there is a certain part. We know that these studies are not perfect. We also don't want to change too much. Our clinics are structured in such a way, our health environment is structured in such a way that there is little we can also do. Let's say you're working in a government hospital where insulin is not freely supplied. In Tamil Nadu, thankfully, that's not there. Then you just have to do glibenclamide 222. Okay, next time sugar is high. Now, why don't you try, instead of morning, you take it in the afternoon and in the night. That's all you can do. So sometimes it is what it is. But then there are patient factors. One is the side effects of medications. I want you to know that patients, the moment that they develop hypoglycemia, they tell lies to the doctors. They'll come and tell the doctors, look, I took all the medications, doctors, but I will tell you that the Galvesmet twice a day would have become Galvesmet once a day. I promise you that would have happened. Irrespective of the fact that it may not have caused a hypoglycemia. Then too many medications. Of 8 drugs, 4 are drugs that are written only to get the patient out of the clinic. Forgetfulness, it happens to all of us. Cost. Who has not felt the cost? Then of course there's a denial of disease. Sir, I have only very mild diabetes. I keep telling my patients, you can only be pregnant or not pregnant. How can you say I am only a little pregnant? Then there is one guy who comes and tells me, in my family there is nobody who has diabetes, doctor. How come you are telling me I have diabetes? I may have diabetes, but I will never have problems with diabetes, isn't it? Then whether you like it or not, they will come in. One is Dr. Google is there. Second is, there will be one half-baked son of his or a nephew of his who has gone to America and who's feeding them information that in America everything is milk and honey. And thinks that the Indian system is bad. And of course, normally the doctors are very poor communicators. On top of that, there is time. On top of that, today there is no doctor who does not see the cricket match on his iPhone when he's seeing patients. So, communication is poor. We may be very literate. I see all our IAS officers are like that. They are very, very, very literate. They will talk everything. But when it comes to health literacy, they are very poor. On top of that, comorbid illness. Now, let us not admit that most of our patients are non-adherent. This is also true. As Everett Koop said, drugs don't work in patients who don't take them. The most important reason of clinical inertia is adherence. But the problem is both clinical inertia and adherence cause increased mortality. Our patients die because of non-adherence. And it is also known that when doctors think that their patients are non-adherent, they do not act. That is the attitude. They will say, "Ye to nahi khayega, main kyun ise bada दूं?" See? So, if you're poorly adherent, the likelihood of your drug being intensified is very low. So, look at this. This is a study that looked at prospective adherence to OHAs. 60 to 75%. I don't believe this 60% insulin. I'm almost certain, and there's enough data to support it, that most of our patients who are on basal insulin at least will drop 2 days of insulin per week. There are some obsessive compulsive guys who will measure it 6 times a day and make your life miserable. The majority of patients will only take it 4 to 5 days a week. Then there are unintentional adherences. Have you ever tried reading an insulin label in Chennai or in India? Very difficult. Our metformins are too big. and then of course our handwritings and our instructions are too confusing, then they're also too expensive. On top of it, forgetfulness is born with us. But there are some very Indian unique stuff. One is fasting. Our Indian way of fasting is no food, no medications, but payasam twice a day, sweets in the evening. One of my friends does Thursdays for Sai Baba. She said, look, our fasting is, Sai Baba doesn't want us to go without food. Sweets and milk are allowed. And the milk is not milk, it is sugar syrup. Then, sir, I stopped it to see if I still need medications. Altering the dose schedule for the convenience. And of course, no doctor, the medicine is not working. How many times did you take? 3 days last week. Then unintentional labels, this stuff. So what do? I don't have too much time. First thing is to know that we are not perfect. That we don't spend enough time. That we don't talk about medications. That we don't talk about goals. The second is to believe that we can change. We can believe we can change is to make small changes. The simplest thing is to assess our practice. There was a beautiful study that showed that doctors think when doctors are shown somebody else's prescription, they can find out enough number of mistakes in it. But when they are shown their own prescription, they don't believe this is what they wrote. So knowing that we are fallible is very important, and it helps us. And communicate. I think it's time to put our cell phones away in our clinic, listen to our patients, and guide them back to the thing. And lastly, self-assessment is a very important tool to reduce clinical inertia. I've done sessions on this before on how to improve practice. The most important is to measure ourselves and start doing stuff. I hope this was, I know I've been growing against the grain and saying lots of bad things today. But I hope some of this goes back with you. And I leave it to some experts to talk about a lot of other stuff. But I don't know if it's clinical inertia. I think it's more we are being sucked in this whirlpool that is medical practice with competing interests. But getting a lifeline and throwing it to the stage and slowly starting bringing order into our lives will help hundreds and thousands of physicians. Thank you for the patience. Thank you for the time. I hope this was useful for you. Thank you.